Hello, and thank you for inviting me to give this talk at your conference. And I'm really sorry that I can't be there in person this year. My name's Sarah Wright. I'm a consultant in neurology at the National Hospital for Neurology and Neurosurgery in London. Now, why do we talk about the bladder and the brain? Well, the bladder is controlled by a complex network from the brain and the spinal cord. And bladder symptoms are really common in neurological conditions. And not only that, is that bladder symptoms really affect quality of life. For example, if you've got overactive bladder symptoms, you might be controlling how much fluid you take before you go down to the shops, or it might stop you from accepting invitations to events with family and friends. And so I really want to talk about how common bladder symptoms are. We'll talk about how the brain controls the bladder. And then we'll talk about some of the treatment options to address and to help with bladder symptoms so that people can, if they feel a bit shy about their bladder symptoms, talk to their healthcare professional. And, there's no need to suffer in silence with bladder symptoms. Now, bladders hold between 200 and 500 mils typically, and might empty the bladder 4 to 7 times over 24 hours, and maybe up to once at night. In 24 hours, you might pass 1.5 litres of urine. But what's interesting is that most of the time, you're not peeing. Only, in fact, 2 to 3 minutes out of 24 hours is spent peeing. So most of the time, the bladder sits in what we call the storage phase. And you'll hear me talking a little bit about what we call storage and voiding throughout the talk. So you can see we have the bladder here, and or the detrusor, it's a muscle. And storage symptoms, which we've heard is 99% of the time in which the bladder sits. The sort of symptoms that people might get when they have storage symptoms are increased urgency, so that desire to need to go to pee and get there quite quickly. Increased frequency, so needing to go more than 4 to 7 times in the day, needing to pee overnight, nocturia, and urinary incontinence or leaking. And so at the bottom of the bladder is the urinary sphincter. That acts like a trap door. So when the bladder contracts, the sphincter relaxes, and that's when you can empty the bladder or void. The sort of symptoms that someone might experience if they have voiding symptoms are hesitancy, so it takes a bit of time for the flow of urine to start. Straining, so needed that feeling of, there's still some urine left behind, and using the abdominal muscles to help empty the bladder. An interrupted stream, and double voiding, where people feel they need to return to the toilet again after 5 to 10 minutes. And so then, to achieve both storage and voiding, there are the connections between up here, the brainstem sitting just below the brain, and all the way down the spinal cord to where the signals to the bladder come out, need to be intact. Because the way that the bladder is controlled and the entire phase of passing urine from storage through to voiding involves the front part of the brain all the way down through the brainstem, spinal cord, and out the nerves at the bottom to the bladder. And so when it's appropriate to empty the bladder, the pontine micturition center, which sits here in the brainstem, which is a specialist center for managing the bladder, gets the signal to relax, or the signal to void can happen. And so the signal's sent down the spinal cord and comes out the nerves down the bottom and what we call the sacral spinal cord. And so when that happens, the bladder can contract, the sphincter relaxes, and then urination happens. But if there's any interruption from a neurological reason anywhere along this route, that's where people can get symptoms affecting the bladder. So particularly if there's any issue with brain lesions or a neurological disease affecting the brain, then people are more likely to have storage symptoms. But if there's problem affecting the spinal cord, then people can have storage symptoms, but they can also, so the bladder is more active, but they can also have difficulty with emptying the bladder because the signal to empty, squeeze the bladder and relax the sphincter doesn't happen at the right time. So in fact, the bladder's squeezing, but the trapdoor is still closed. And so that's what we call detrusor sphincter dyssynergia. So there's a dyssynchrony between what we expect to happen for voiding to occur. And so you can see here, the bladder's filling up. And as the bladder's filling up in the storage phase, the signals, and the bladder's now full, it's yellow. You can see the signals are traveling all the way up the spinal cord into the pontine micturition center and this other area in the midbrain, saying, the bladder's full. Is it time? Can we send the signal to pee? And so first, what needs to happen is it an appropriate place? And that's where the front part of the brain comes in. Is it socially appropriate for me to pee right now? Am I close to the toilet? And so why we're talking about the bladder in this conference as well is that both bladder and bowel problems are common in men and women with mutation of the ABCD1 gene in X-linked adrenoleukodystrophy. In fact, that's both in men with AMN and female carriers. And they both have a severe storage symptoms. So you can see here, 75% of people reporting at least one urinary symptom, which is, a significant number of people. And so how do we do an assessment of bladder and urinary symptoms? So first is taking a history to really understand, is it more the storage, the overactive bladder type symptoms, or is there a problem with emptying as well? And then to understand how is the bladder emptying. And we do that with measuring a post-void residual scan. So that's doing a bladder scan after you've peed to see how much urine is left behind. Might also do a bladder diary that you can keep at home over a couple of days, 2 to 3 days. And that looks at what sort of fluids are you drinking? How much fluid are you drinking? How often are you passing urine? At what times? Is there urgency when you pass urine or any incontinence? And that gives a lot of really useful information. And then as well, some people may require more complex tests like urodynamics, which looks at the bladder structure and function and the voiding phase in detail. And then we'll talk about what's the most appropriate treatment option. So this is how we measure how much urine is left behind. And this is a post-void residual scan. So it's just very simple. You can see sorry, I lost my mouse. You can see the probe there. It's just like similar, any simple ultrasound scan, just at the lower part of the belly. And so then thinking about how we can manage all of these symptoms, this is why it's really important to be clear what exactly are the main symptoms that you're facing, because there are plenty of different options depending on what your main problems or the person's main problem is. And that can be overactive bladder medication, pelvic floor exercises. Some people have, depending if they've got some pelvic floor issues as well, potentially surgical options through the urologists or the gynecologists. And so I'll just talk a little bit more about these measures is behavioral training or bladder retraining, pelvic floor exercises and abdominal stimulation, because these are the sort of things that you do at home. and then other treatment options and appliance options that we have. So just generally, this is where it can be individualized and where the bladder diary is really helpful, because there are certain drinks and beverages which really irritate the bladder, and caffeine, so switching to decaffeinated beverages or cutting down caffeine, because sometimes it may not be clear how much caffeine someone's drinking, and then you get a bladder diary and realize, wow, someone's actually drinking 7 cups of coffee a day. Alcohol, strong citrus fruits and juices also irritate the bladder, as does sparkling drinks, so sparkling water, fizzy drinks. And I put this here, the Radar Key Scheme. So this is one of the companies who provide priority keys or priority access keys to accessible toilets. And so you can just search for that online. The next aspect of bladder management is behavioural training or bladder retraining. And this is aiming to take control of your bladder rather than your bladder controlling you, and avoiding just in case going to the toilet. And so the idea is, when you, and a very common scenario is what's called latchkey phenomenon, where people get home from being outside the house, they put the key in the door, and then really need to go to the bathroom to pass urine. And so then the idea of bladder retraining is, when you feel that urge, is to distract yourself for 30 seconds or 1 minute, and then go inside the house and go to the toilet, and then gradually increase that time as you can. And if you have more difficulty with emptying the bladder, then we generally say you shouldn't hold on more than 3 hours during the daytime. In terms of pelvic floor exercises, the pelvic floor is a hammock of muscles which sits in the pelvis, and having good control of the pelvic floor and a strong pelvic floor can help to manage urgency and other symptoms. And some links here, there's a Squeezy app, and also Natalia Vasquez, who's a pelvic floor physiotherapist specialist in our department, has made a series of YouTube videos which you can either search Natalia Vasquez pelvic floor, or there's a link there as well to follow. Now, in terms of the next aspect of the talk, we'll talk about some different treatment options. And first, the first-line treatment after people have done general measures, such as bladder retraining, avoiding certain fluids, pelvic floor exercises, is overactive bladder medication. And now these can only be used if you have storage symptoms and you are emptying the bladder, so there's less than 100 mils left behind. We wouldn't start or recommend starting overactive bladder medication if you are retaining some urine. So there are plenty of different options, and we have some of the older options such as oxybutynin, which we tend not to prescribe as much these days, and the more modern antimuscarinic medications such as trospium and darafenicin. Mirabegron is also a newer option for managing these symptoms. So in terms of antimuscarinic medications, there has been some concern that the receptors that they target are in the brain as well as the bladder, but the more recent overactive bladder medications that we have, the antimuscarinics such as trospium and darafenicin, actually don't remain in the brain at the brain receptors. They're actively extruded by the receptors there. So they're what we call cognitive sparing antimuscarinics. So you can see there are a number of different options, and they all have a different duration of action. And some of them are once daily medications, some of them are 2 or 3 times daily, and it all depends on what suits you. Say, for example, you might be someone who just wants to have a bit more control of the bladder on a long plane trip, for example, or a long train trip or car trip, and so you might just take some fast-acting tolterodine, which only lasts its half-life is 2.4 hours, so only lasts about 5 or 6 hours, and you just need that to get through a specific scenario. So there are multiple different options which might suit you for different reasons, and those should be discussed with your healthcare professional. In terms of other treatments that are non-pharmacological or don't involve tablets, something called tibial nerve stimulation, where some electrical stimulation is applied to the tibial nerve, which is behind the ankle bone here. And the tibial nerve runs up the back of the calf into the back of the thigh, up into the bottom of the spinal cord. And modulation of the nerves there, because that's where the nerves of the bladder come out, helps to reduce overactive bladder symptoms. And it can be either percutaneous, using a very slim needle electrode, or transcutaneous, which is using the sticker electrodes. Some people may go on to have botulinum toxin injections to the bladder, and this is where botulinum toxin is injected into the wall of the bladder from the inside, and the effect for this, for overactive bladder symptoms, can last between 6 and 12 months, which varies for different people. So you can see there are a number of different options depending on the particular problem that someone might have. And then when selecting what's going to be the best management, it depends on a lot of different factors. And this is where it's individualized. So there may be some personal preference as to what people may or may not want. If people require assistance to get to the toilet, what are the symptoms that bother you the most? And in terms of dexterity, using the hand, eyesight, and how easy it is to separate the thighs for some people, are all factors which your continence specialist would be considering when thinking about the best plan or best management plan. In terms of containment products or pads, we have pads on the right here. They're all different options depending on what someone might need in terms of absorbency and size. And on the left, there's some other options for containment, something called a convene or a condom sheath, which goes over the penis and captures urine. Now, that's something that, for example, might be particularly helpful if someone is up to the toilet frequently overnight, but is at risk of falling. And so that's a way that urine can be captured and contained without, say, for example, requiring a catheter, but might be suitable for that particular situation. Now, some people may have some retention of urine, so there's more than 100 to 150 mils left behind in the bladder when recording with the bladder scan. And in this situation, the bladder symptoms, and there may be an increased risk of urinary tract infection as well. We need to consider ways to empty the bladder. And so that would be, if depending on kind of hand dexterity, eyesight, able to separate the thighs, may consider something called intermittent self-catheterization, where a disposable catheter is inserted into the urethra, and through all sorts of different catheters and with guides here that you can see as well. And then the bladder is drained, then that catheter is disposed of. And people may do that several times a day. They may do that once a day or several times a week. Again, this is where it's individualized. Now, if it's not possible to use a self-catheter or self-catheterization, then a permanent catheter may be considered, and that can be either urethral, so via urethra via the penis, or in females, so the female urethra, or suprapubic, which is where in a procedure done by urologists, a catheter is inserted through the wall of the stomach and directly into the bladder. And again, there are all sorts of different options with catheter bags and with more of the belt style, different valves as well, which may be used to manage the flow of urine from the catheter. So in conclusion, bladder problems are very common, and the treatment and management of bladder problems is very individual and should be discussed with your healthcare professional to find the best way in which to manage the most bothersome symptoms for an individual, because as I've discussed today, there are a number of different options. It's been a pleasure to talk to you today, and I hope you enjoy the rest of your conference.